Okay, perfect. Good evening, everyone, and thank you for joining this webinar this evening. So this is the third in the series of the August Seminal 6, where we pick a topic and we pick the biggest trials of the moment to discuss as a means of update in that area. And tonight, the special topic is gastric cancer, and we have two phenomenal speakers to give us updates this evening. So we are delighted to have Professor Shiraz Marker and Dr. Lizzie Smith joining us this evening. So Professor Shiraz Marker is a professor of esophagogastric cancer at Oxford University, and he's director of Nuffield Department of Surgical Sciences Surgical Interventional Trials Unit. His research focuses are on cancer survivorship, surveillance, and improving surgical quality in upper GI surgery. He is a double PhD graduate of Imperial and Karolinska. He's a Hunterian professor and UEG Rising Star Award recipient, and he also serves as surgical specialty lead for esophageal cancer at the Royal College of Surgeons of England. We also have Dr. Lizzie Smith joining us. Dr. Lizzie Smith is a consultant medical oncologist and GI oncology lead in Oxford, as well as the clinical lead for the Oxford Clinical Trials Office and deputy lead for the Oxford Experimental Cancer Medicine Centre. She leads national and international trials in immunotherapy and targeted treatments for esophagogastric cancers and has authored more than 200 publications across major journals. Dr. Smith is chair of the ESMO Guidelines Committee and chair of the Eurotech GI Trials Group and is a long-standing educator and mentor in global oncology. So we're in very good hands this evening. So with that, I'll hand over to Professor Marker, who's going to kick things off for us. And just in the interest of time, we might hold discussion until the very end. And if people have questions as they go through, please pop them in the Q&A, and then I'll feed them back to our speakers at the end. Thank you.
Great. Many thanks for the introduction, Nicola, and many thanks to Otis for the kind invitation to talk today. We thought we'd cover a couple of topics actually in gastric cancer. Lizzie is a rock star in medical oncology, so I would be doing it a disservice if I was to give that talk. So I'm going to focus really on my area or my kind of real passion, which is on basically advancing what we do with gastric cancer and potentially expanding the treatment options for our patients. So I'm going to talk to you about the Renaissance trial. So I'm going to frame it really largely speaking around this. And I think what we've started to consider in Oxford and some centres across the country is really whether or not we can treat patients with limited metastatic disease with a curative intent. And this is really, I think, sort of a really, really important point in time for how we treat this disease, and may actually really change the way practice for in the next 5 to 10 years. So it really comes from this, which is basically the AAO FLOT3 trial, which basically looked at essentially patients receiving FLOT, but it's arm B, which was perhaps the most interesting group, which was essentially 67 patients who had limited metastatic disease. And what they were able to show was in that group, in the survival curve and survival curve T, those patients who had surgery with limited metastatic disease actually had an improved overall survival. So this challenged the belief really at the time, which was that patients with metastatic disease were incurable or had very, very poor prognosis. So I think this is a really important piece of work at the time. This led to the Germans undertaking the Renaissance trial, and this is a really, really, I think, important trial, partly because it highlights that clinical trials are very difficult to do. This was a really difficult trial to recruit to, and also it shows that in actual fact that sometimes the field can change during the course of a trial, and I think it's important to consider this. So essentially, Renaissance randomized patients with what they described as limited metastatic disease to either, after having FLOT, 4 cycles of FLOT, and showed disease stability, to either having surgery plus another 4 cycles of FLOT, or essentially best systemic therapy. And I think what was interesting in the group was basically the definition of what they described as limited metastatic disease, which we'll get into it. What was important was the site as well. So they included really realistically any site, so liver, lung, adrenal, in terms of hematogenous spread, but also peritoneal disease, as well as patients with lymph nodes outside the field. And I think what's important to understand is that this trial, when it was set up, was quite some time ago. So they did the right thing, what they felt at the time, in terms of the German investigators who really led the trial, and Stefan Munich, who was the surgeon on the trial. Um, so as you can see here, there's a whole host of basically essentially where the site of limited metastatic disease was. But in reality, the majority of patients had liver mets, but also they had a high proportion, around a quarter of patients who had peritoneal carcinomatosis. And I'll talk a little bit about that moving forward as we start to think about the landscape in the UK. So their primary endpoint, and it was stopped in terms of the trial because of futility in the primary endpoint and really challenges with recruitment. But they were able to recruit 67 patients in the intervention arm and 72 in the control arm, which is actually quite an achievement, to be honest. But they showed no improvement in overall survival associated with surgery in patients with limited metastatic disease as they defined it. And I'll talk about the challenges with that in a second. But what I think is important is really start to look at the groups in potentially a little bit of detail. So if we were to break down these groups, and I'm very grateful to Stefan who provided me with these slides, but basically what was interesting is that in the retroperitoneal lymph node group, there does appear to be an improvement in terms of survival for patients who have surgery in that group. And I think some of us who have trained in units whereby we did that fairly routinely would consider that's a good prognostic group if you're going to operate on them. The liver metastasis group really showed no real change in terms of surgical intervention at all in terms of survival. And what I think was perhaps most important is, in actual fact, surgery appeared to be harmful in the peritoneal group in terms of a very poor overall survival in the surgical intervention group. So it perhaps showed that the peritoneal group needs to be thought about completely differently in terms of whether or not surgery has a role in that cohort at all. So these are pictures of my children. I put them into lots of my talks, but essentially for me, the take-home messages from Renaissance is that there was very heterogeneous inclusion criteria in terms of the site of metastasis. They had a very broad inclusion criteria, really allowing up to 5 liver metastases, which by kind of modern or the OMEC definition would be considered quite broad in nature. The other thing as well is that the quality of surgery, because the number of centers was quite high, the quality of surgery wasn't controlled within the trial. So therefore they had quite a high rate of reoperation. I must say more than 20% in the retroperitoneal lymph node group. Lizzie can also talk about this as well, but I think molecular oncology, particularly in this cohort of patients, has changed substantially. And it could be argued that the systemic treatment options they had at the time were perhaps poorer than what we have currently with molecular targeted therapy. However, I would say that, and this is perhaps my own bias, but I do think that there was a prognostic signal in the retroperitoneal lymph node group seen in the trial. So what's changed in the field is that we have now a European definition for oligometastatic disease. I appreciate it's not everyone's cup of tea and it's not what all of us would necessarily agree with, but it is the best definition that we have currently available, which is the OMEC definition, which allows basically up to one organ with up to 3 metastases or 1 extraregional lymph node station. And as you can see, liver, lung, adrenal, and brain and soft tissue mets as described there. However, what I think is important to understand, particularly as the OMEC group in Europe are moving towards a trial in this cohort now, whereby they really want to look at, they don't think there is currently equipoise on whether or not to treat patients with oligometastatic diseases. They want to move towards a trial looking at long course versus short course chemotherapy. However, I would argue at the current time that this criteria has never been formally assessed in a randomized control trial. So that's what we hope to do within the RELOGO randomized control trial. So this trial is now at the funding application stage with the NIHR HTA. And essentially what we plan to do is test this definition of oligometastatic disease in patients with liver, lung, and adrenal mets. So taking the hematogenous group, excluding patients with peritoneal disease and excluding patients with lymph node metastasis, but looking at after they've had optimal systemic therapy for at least 6 months, then randomizing them to either surgical resection and treatment of the Mets, and that can be either by surgery or by ablative therapy versus best systemic therapy. Our primary outcome is a co-primary outcome of both quality of life and overall survival, which I think is very important. Yeah, hopefully watch this space, and hopefully I'll have some more news about that in the next few months. It's a really exciting opportunity, I think, for us in the UK to lead a trial in this area, looking at patients with limited metastatic disease. So with that, I'll stop there and I'll hand over to Lizzie, who will hopefully take us through the panacea of medical oncology.
Wow, you give me loads of time. That's brilliant, Shiraz. Thank you. That's great. So thank you, and thanks to August for the invitation to speak here this evening. So I'm going to kind of touch on not just one trial. Obviously, I'm going to talk about Matterhorn as the predominant study, but also kind of the context for that. So I hope you can see the slides. So can you see it?
Yeah, all good.
No, that's the right one. Yep, there we are. Okay, so what I would say is, so these are, obviously I'm involved in ESMO and write the ESMO guidelines, and we have big changes this year for perioperative gastric cancer and esophageal cancer. I'm not going to go into esophageal cancer this evening, but for gastric cancer, traditionally we've done perioperative chemotherapy, and that's going to change because it will be perioperative chemotherapy and immunotherapy. And obviously for esophageal cancer, we're going to move away from chemoradiotherapy towards perioperative chemotherapy and immunotherapy. So those patients are all going to be lumped into the gastric cancer paradigm. Adjuvant nivo is only for squamous cancer patients in future, but it's not really the topic of discussion today. So this is FLOT. This is what we use when Shiraz sends me patients. This is the discussion I have with them. It's a long path, right? So 2 months of chemo before surgery, 2 months after surgery, at best we cure half previously. And so this is the message that, I know my beautiful surgical colleagues tell the patients that, we'll cure them, and I tell them they have a 50% chance of being cured. FLOT is difficult chemo if you haven't used it before, and I know there's a lot of concern in the field, maybe not in the UK because we've been using it for years, but certainly in maybe America, places where chemoradiotherapy has been the norm. 3 chemo, it's like, we're at maximum cytotoxic load here, so we can't add in more chemo there. We need to be smarter. We need to add non-cytotoxic targeted therapy or immunotherapy, and that's what's been done. So this is Matterhorn. Matterhorn was presented at ASCO this year, published in New England Journal on the basis of event-free survival outcome, which was the primary endpoint. Large trial, so 1,000 patients, global, so gastric and junctional cancer. Because it was global, probably majority gastric cancer, randomized to either FLOT and durvalumab, which is an anti-PD-L1 antibody, very much in the vein of nivolumab or pembrolizumab. And plus or minus FLOT. So it was Asia versus non-Asia stratification. They did cap Asian enrollment because we know Asian patients do better overall. And the biomarker that they used for PD-L1 assessment was TAP. And we don't use TAP generally in the metastatic setting. We use CPS, but broadly speaking, these have been demonstrated to be the same. So don't get too tied up in the biomarker. Patients were randomized 1-to-1. I would say the only issue in terms of trial design in workup was the patients did not mandate laparoscopy. So many patients had laparoscopy, but many Asian patients did not. And the patients in Asia also had much more advanced disease because, as you know, Japanese guidelines and Korean guidelines would recommend perioperative chemo for only very advanced disease, so PT4 and bulky lymph nodes. So it's possible that there were some early metastatic patients included in the study. Generally, they followed the FLOT paradigm, so FLOT before, FLOT after 2 months, and then continued durvalumab for a year. I think we could question about whether that adds value of toxicity. It certainly adds financial toxicity. So these are, I think, the outcomes that are really important from a surgical perspective. It didn't stop giving FLOT and durvalumab didn't stop patients getting to surgery. The same proportion of patients received all their FLOT preoperatively. 90% of patients in both arms went to surgery. Not all were resected, and that speaks to the really locally advanced nature of some of the patients who went on study. There were no but what's important is there were no toxicity dropouts because of durvalumab. And that's what we'd expect, right? Because the toxicity of immune checkpoint inhibitors tends to happen after, 3 months or 6 months. Earliest is probably 6 or 8 weeks for most patients. So you wouldn't really be expecting toxicity in the neoadjuvant setting. And there is a surgical paper coming out that Daniela Molina will write, and there were no excess toxicity, excess surgical morbidity. So Flavia and Dindo outcomes were the same, etc., for all patients who went to surgery. So I think that's really important. These are the event-free survival results. So this is what was presented at ASCO and published in New England Journal. So if you ask me, shouldn't we be using overall survival? Event-free survival is an important endpoint for this population. When you see a patient with metastatic disease, it has a really important effect on the morbidity of the patient. It has an impact on their quality of life. So the longer that we can avoid disease coming back, that's a win for me, and I think a win for the patients. So there was a 30% improvement in event-free survival at the first interim analysis. That was the primary endpoint, so sufficient to call the study positive. These are the subgroup analysis for EFS. We don't yet have the same analysis for OS. And I think this actually caused a lot of surprise, to be honest, in the field, right? Because the pre-stratification was for TAP positive and negative, so under 1, which we would consider negative, and above 1. Interestingly, so in the metastatic setting, when we measure PD-L1, about 60% of patients are positive and about 40% are negative. However, in Matterhorn, 90% of the patients were positive. Now, this draws into question whether early disease is different from an immunological perspective than late disease. And the answer is yes. So if you biopsy the liver, you will very rarely find PD-L1. If you biopsy a bone, you will never find PD-L1. Similarly with peritoneum. If you biopsy a primary tumor, you will usually find PD-L1 at the leading edge of the tumor. And we know that tumors become progressively more immune evasive as they evolve, right? So this is why. So there's, some people will say that we shouldn't, that in metastatic disease, we know that immune checkpoint inhibitors don't work if you're PD-L1 negative. And here they did seem to work. I mean, certainly the hazard ratio it's an underpowered analysis, small group of patients. Hazard ratio is definitely in the right direction. And I am willing to take a punt on the fact that patients with a localized tumor have a different immune tumor microenvironment than patients who've developed metastatic disease. Bottom line, this works for all comers. Whether the license and the funding will be for all comers, I do not know. What's interesting here is that you can look at the higher levels of PD-L1, TAP 10 and less than 10, 5 and less than 5. You can see for 5 and less than 5, hazard ratio is pretty much the same. But even for kind of more than 10 and less than 10, they're good. So I'd be satisfied based on this. We haven't seen the same for OS yet. The OS results were presented at ESMO last month in Berlin. And you can see here that the survival is improved. It's incremental. It improves over time. So you've got 4% difference at 18 months, 5% at 24 months, 7%. We know that it's the tail of the curve that matters with immune checkpoint inhibitors. So overall, the hazard ratio is kind of just under 0.8. So you might say that it's a 20% improvement in overall survival, which is not bad. So it's curing more patients. The question that we haven't seen answered is, are the OS results really? So according to, if you look at the OS results with PD-L1 positive versus negative, you can see that actually they were equivalent, right? So if you take positive versus negative, I would like to see, excuse me, if the delta was bigger for the PD-L1 CPS 10 group, the very immunogenic group, but that data has not become available yet. I think that might be important for funding. So I'm interested to see how this goes at NICE in terms of the cost benefit ratio, because the survival improvement is good. It's certainly better than Filad alone, but it is not, it's not knocking it out of the park. And so I think that the important issue will be whether we get it funded at the NHS. Now, I'm going to give you a few words just on other targets so that we can bring these into the conversation, because it's the direction of travel and where you as academic surgical oncologists might be thinking about taking trials. Shiraz has talked about our logo, which is great. We know HER2 therapy works in the metastatic disease. We've tried many times with academic trials to get it through in the perioperative setting, but these patients are hard to find and difficult in academic trials to recruit. So Germans have done well in a couple of trials. Petrarca showed the beginnings of a DFS benefit, but it closed early simply because in a negative trial in the metastatic setting with pertuzumab, there was also, I don't know what happened there. There was also the EORTC innovation study that showed that adding trastuzumab to chemo improved disease-free survival. You add a second HER2 drug, it doesn't help. That actually hinders because you add toxicity. And then we had this really nice small German study again shown at ESMO gone by, PERFLOT, using chemo, trastuzumab, and an immune checkpoint inhibitor. And you can see really nice response rates there. So 50% complete response. The higher the HER2, the higher the PD-L1, the better the response. So there are HER2 studies ongoing, mostly using the antibody drug conjugates, so TDXT. And I would say probably within 5 or maybe within 2 or 3 years, we'll have national studies looking at adding HER2 ADCs into the perioperative setting. MSI is important as well. I know you're probably all checking that in your gastric cancers. You know these very exciting results from France. Small study, they're always small because it's a rare group. 30 patients treated with doublet immunotherapy, 60% pathological complete response. You could argue, of course, that these patients didn't need surgery, and that is the valid next step, right? It's looking at the MSI patients in Matterhorn, so they also did very well in Matterhorn. Infinity, which was an Italian study, also took doublet immunotherapy, similar PCR results in the first part of the study to Matterhorn, and then they went on to not operate. So, maybe we can talk, Shiraz and I often talk in the MDT or outside the MDT about how we should approach these patients, because we know with chemoimmuno, we're seeing, not just the MSI, more patients in PCR, and should we be doing surgery? And if we're not doing surgery, how do we know that they're really in a CR? So what they did in Infinity was PET, ctDNA, done by biopsies, and a certain proportion of patients went on to have a non-operative approach, and most of those who went on to have a non-operative approach did not progress. Important to note, the only patients who were eligible for non-operative approaches were PT3 tumors. The PT4 tumors tend not to go into PCR. So you need to keep operating on those. So this, to me, is still experimental. We expect these patients to have a great outcome with Matterhorn. Oh, that's the second part. A great outcome with Matterhorn type treatment. And because we don't have access to doublet immunotherapy in the UK, I don't think that I could recommend this unless you were treating off-label or the patient had access to doublet immunotherapy. And you do need 2 drugs. So you can't just use one immunotherapy drug. The doublet immunotherapies in both of those trials was including anti-CTLA, which is a much more powerful immunotherapy than anti-PD-1. So if you use anti-PD-1 alone, this was done in a French trial by Christelle Lellouche, the PCR rates are much lower. So you either need chemo and PD-1 or PD-1 and CTLA-4. You can't do PD-1 on its own because unexpected CR, you can't expect those same results. Okay, so these are questions that we need to ask in future for the perioperative disease setting, right? So what we're doing now is we're giving flat durvalumab, we're doing surgery, and then regardless of whether they have a good response or a bad response, we're still doing the same thing. I think what we need to be thinking about in particular, because we have a lot of fancy new chemotherapies in terms of ADCs, antibody drug conjugates, which are targeted chemos, we could consider switching treatment in the adjuvant setting, but we could also consider switching before surgery, right? Because we have PET, we'll probably have ctDNA in future, and so we know which patients are responding or not. And so probably after a cycle or 2 of chemoimmuno, we should be trying to understand which patients are benefiting and maybe continuing those to total neoadjuvant, or switching or not, or straight to surgery for those who are not benefiting. So those are studies that we're working on. And this is, I think, the main reason why, because you all know that in the adjuvant setting, even though we set out with good intentions, a lot of patients are not fit for treatment. I will say that in Oxford, 90% of our patients have their adjuvant treatment, maybe more. I'm really mean. No, I'm not. I wait for about 12 weeks. I will wait up to 12 weeks for them to improve. And I always start them out on a dose reduction after surgery, and they all get their treatment. If they're in a PCR, they get their treatment. If they have a miserable lymph node count, they get their treatment. So, because we have evidence from clinical trials that even those in a PCR they have a chance of recurrence. And even those with miserable lymph node counts, based on VICI, benefit from Morphlot. So I think we're fairly rigorous, if we can, about giving the patients their treatment. So this we are for our treatment of our perioperative rodeo this evening. So we need to improve systemic therapy. Surgery is already there. Durvalumab is the new standard pending, obviously, funding decisions or expanded access. We will move forward with HER2 and MSI in future, but we have a lot of work to do, I think, in terms of personalizing the therapy in this setting. And radiotherapy, we'll discuss. We're not doing that anymore for our junctional cancers. All right, thank you very much. Now, let's have a discussion.
Thanks very much. There's two brilliant talks there. So just so everyone is aware, the chat is not enabled for everyone. So if you just use the Q&A for any questions you might have, or else just pop your hands up. And I think we have one person with their hand up. Amy W., do you have a question? No.
No. Okay.
Sorry, that was a mistake.
Oh, okay. No worries. I might just kick off. I have a few questions. Dr. Smith, if you don't mind, just because it's an invested interest of mine, because I'm looking into HER2 in the context of esophagogastric cancers. Should we be testing everyone regardless of their stage? Because that's currently not standard, certainly in Ireland anyway, across centres. And I'm just wondering, what do you do in your centre, and what do you foresee the future holding?
So I think so. I've been running an adjuvant HER2 trial for kind of a little while in the UK, and we do. I think most places in the UK do test HER2 reflexively now, even though it's not really informing you of much at that point in time. I think that it's good to have the information available if the patient becomes unresectable, or they're not tolerating FLOD, and you need to move to a metastatic paradigm. I also think if you have access, for example, to chemotherapy, trastuzumab and pembrolizumab for patients with very locally advanced, maybe borderline unresectable cancers, that's the path you should be taking. So because that's got super response rate. So I think it's very useful just to have as much information about the tumor as you can. So yeah, I can't say that there is a robust financial case for doing it now, but HER2 IHC doesn't cost much. So I think that we should probably do reflex testing for our patients. So we tend for operable disease to do HER2 and MMR. If it looks like a nasty tumor, we'll get PD-L1 and Claudin as well, just so we have our ducks in order.
Yeah. And that Petrarca trial that you mentioned, that was closed based on the results from the Jacob trial, I think, wasn't it?
Yes.
It was a bit, do you think, unfair, or do you think that was justified? Or
Well, so this is what this is the difficulty with I think it was always going to struggle. It was never going to be a registration trial, because one of the challenges in gastric cancer with HER2 directed therapies, and this is kind of what you learn if you work in drug development like me, is so we never got the attention in gastric cancer with trastuzumab that breast cancer did, because it's a life cycle issue, right? So when a drug company develops a treatment, they will only derive a profit from it for a certain number of years. And when they get towards the end of that life cycle, they don't want to invest in clinical trials. So that is why we did not have trials with trastuzumab in gastric cancer that were run by industry. HER2 positive gastric cancer in the perioperative setting is quite a challenging group to recruit to. And I don't think that any academic trial will ever move the dial. We can do them and show that it is, this is a useful thing to do, or, this is a group at risk, but it will need to be a commercially driven trial that introduces HER2 therapy. And so whether that will be with trastuzumab deruxtecan, which is an antibody drug conjugate that we use in metastatic disease, or another type of HER2 drug. We have zanidatamab now also coming through in the metastatic setting. I don't know, but it is a gaping hole that when we know that targeting these patients is really helpful, that needs to be developed. But unfortunately, gastric cancer has always been the poor relative of breast cancer in this field.
Yeah. Okay, great. Thank you. We have one question in the Q&A from Leo Brown. So, although no trial evidence yet, do you think giving 6 to 8 cycles of FLOT preoperatively will become part of the treatment pathway for OG cancer in those who are tolerating treatment well? There are some centers around the world who have already moved towards this approach.
They do that often in America, and I understand why, because a lot of patients don't get their adjuvant. I think if you're patient, you can give the adjuvant. I would say, Shiraz, you think the patients would get pretty deconditioned. I would like to do it for responding patients. It's
That's
not
my
for
point.
all
Yeah,
comers.
yeah,
Yeah,
yeah. So I agree. So I think so. The question is basically what are you doing with the 6 to 8 cycles?
yeah,
So you're either providing benefit to the patient in terms of they're actually responding, or you're just
yeah,
trying the biology of the cancer.
yeah,
Basically, you're waiting for time,
yeah,
essentially. So you have to be very clear about what you're doing with
yeah,
that. So I think the 6 to 8 cycles and a patient who's responding, if you can adequately assess response in the neoadjuvant setting, well, is acceptable. And it may be something I know Tim is working on a trial with a few others really around this, Tim Underwood, but I think we're a little bit away from that in the UK, partly at the moment because we are struggling, I think, to have a robust way of identifying patients who are responding very well to neoadjuvant setting, or a validated way, I should say.
yeah. I think,
But it will come. Yeah,
PET
yeah,
PET
yeah,
is useful, and I think that we should revisit PET,
yeah,
especially because, I think that we'll be able to reinforce that with maybe ctDNA assays in future. But so definitely there could be value in total neoadjuvant treatment, but
yeah,
not for everyone.
yeah,
There's some patients we should be stopping before 4 cycles, no doubt.
yeah. No, exactly that.
Okay.
Um,
Do you think, sorry, we're just waiting on more questions to come in, but do you think you mentioned it already that ctDNA might be a player in that field? I was going to ask about ctDNA to decide on the use of adjuvant FLOT, much similar to the way it's now being used to decide on adjuvant treatment in colorectal cancer, and whether you see that being the process to decide on
So,
adjuvant FLOT.
in fact, I'll let you in on a little secret. So, ctDNA to decide adjuvant treatment in gastric cancer has bombed, right? So, this is never going to happen. First, in colorectal cancer, first of all, I would say, dynamic shows that we can't really stratify for the assays that we have in GI cancers are not sensitive enough to discriminate. I think because these patients develop peritoneal disease, right? The other issue is that in stomach cancer, patients are receiving neoadjuvant treatment. I know, I think it makes some of the cancer cells a bit quiescent and they don't shed the ctDNA. So if you look at Plagast, you'll see that there's a lot of patients. It's not sensitive enough to detect, all the potential recurrences. I've done, I have my ctDNA HER2 trial in the UK. We have screened so many patients, and what happens is, um, in half the patients, so first of all, there's a big attrition rate after surgery. In half the patients who are ctDNA positive, when we screen those patients for the trial, they have METs.
yeah,
So
yeah,
the issue is that we don't do a routine post-op CT, and ctDNA is such a bad prognostic factor for in the positive setting that if you find it, that patient already has METs almost invariably. So we can't do ctDNA positive trials, and yet the ctDNA negative patients, still half of them will occur. So it's not enough. Obviously, sequential testing or serial testing gives more sensitivity, but I think the issue with the peritoneal metastasis and the kind of quiescence after neoadjuvant therapy has ruled that out. And so what we are doing with our ctDNA trial at the moment is we're changing it. We've submitted an amendment for an MRD trial, so based on pathology. And I think we'll be doing a lot more digital pathology. And they're doing the same with the Italian trial. That was the exact same design. So I would say that we should right now we cannot think about stratifying based on ctDNA. It's not going to happen.
Do you think, Lucy, that one thing I was going to ask was basically, do you think that the patients who have sort of a very poor response based upon ctDNA to neoadjuvant therapy, that's the group to pivot in? Because if you operate on those patients, we know they recur pretty quickly. So we have some data to suggest that. So whether or
I
not,
think we need bigger data sets
yeah,
before we make such a life-changing decision, because there
yeah,
are patients who will have a high. I agree with you. You're right. Those patients are bad prognosis, but there is a group of those patients who have a high ctDNA shedding from the primary tumor, but don't have METs.
hmm,
So and it's very hard for me, to deny someone a potentially curative treatment
yeah.
in that setting. So I know where you're going with that, but I would be slightly concerned.
Yeah.
Mm. Another question in here. Do you think the move towards immunotherapy in the curative setting could lessen the need for more aggressive, surgically morbid lymphadenectomy?
One for sure, I think.
So I have a real problem with this, Leo. No, I'm sorry. So what I would say, no, look, so to be honest, what we don't know, and I think it's a really important question, and it's something actually that we're just sort of exploring with Simon Bazaki, who's one of our colorectal colleagues. He did a similar paper really looking at the value of lymphadenectomy in patients with colorectal cancer. And I think the question is basically, is actually, are lymph nodes protective in patients who have immunotherapy or adjuvant immunotherapy? And that's a question we don't really know the answer to now. What I would say is doing radical dissection is not morbid. We have to get away from this. This is like an old-fashioned view that we used to say 10 to 20 years ago. It's not the case anymore. Basically, you do a good operation, high-quality operation. Your job as a surgeon, I always say this, is to get the tumor out. So I think where it's changed for me from my training to now is that if I don't think I can get the tumor out with an R0 margin, then I turn to Lizzie and I say, okay, what are the options for best systemic therapy, or how can we get better control here of the disease, basically, because that's what you have to do on the initial staging. Are you going to get an R0 or are you not? And can you clear the lymph nodes, yes or no? And if you can't, then you need to start to think about other options. And you have to be, I think, the change for surgeons has to be is that we have to be very honest about it and say, well, in actual fact, we could do potentially a D3 dissection. It's probably not the right thing for the patient. The right thing for the patient is to give them best systemic therapy and then look at them again for resection.
Or not, because
or
I think
not.
the bigger question, the question is, I would say the question is not lesser lymphadenectomy, but can we take a very radical approach to this patient, or is this a patient who will go into a PCR, right? Because I think you have operated on patients who we've here who've been in PCR this year, and I'm delighted actually. I'll be honest, as an oncologist, I would rather the patient has an unnecessary surgery. Because we do not have the tools yet to tell us if the patient is in a CR. I mean, I've done it in colon cancer as well after immunotherapy. There'll be a little lymph node increasing in size. You won't be able to biopsy it. You're going to give them some horrible chemotherapy and you're not going to be treating anything. You're just treating a little fluctuating lymph node. So I would much rather that the patient has surgery and I just know, okay, you're cured, to be honest. I'm a very pro-surgical oncologist.
I know,
I know, right?
Could I ask Prof. Marker just about the Renaissance trial? So the retroperitoneal lymph node group, which you pointed out as being very interesting, like, did they resect that lymph node or did they leave that lymph node where it was? Because obviously robotic, that becomes a lot more accessible now, and just wondering what you think about that.
So I think probably the best data set to really examine that issue is from Franco Robiello in Siena. So Franco I love, because Franco basically did D3 dissection on every gastric cancer in a neoadjuvant naive population to really understand. Well, he didn't do it to do that, but it allows us to understand basically those patients whereby they have positive retroperitoneal lymph nodes, how they behave in a neoadjuvant naive setting. Now, in the Renaissance trial, around 50% of those patients had the retroperitoneal lymph node resected versus not, actual facts. So what I would say is it does start to make you think basically whether or not you have to go and chase the lymph node or you leave it for your ablative therapy down the line. I mean, this is a reasonable option. If you think the surgery is going to be pretty morbid doing a D3 dissection in your hands, or you're worried about it in the patient population, it's a very reasonable thing. If it's no longer PET avid, to then go and say, okay, in actual fact, I'm going to leave that behind down the line, and we'll monitor it, and we'll just resect the primary if there's tumor in the primary.
And they had a very high reoperation rate, over 20% in that group. What did they say why that was, or was that just morbidity due to the dissection involved, or?
Yeah, so I think it's morbidity. So the D3 dissections they get, because obviously you're operating in sometimes a pretty tricky area. So it's not typically, it can be for rebleeding, obviously, but a lot of it's down to lymph leak. Unfortunately, there's a lot of lymphatics in that area, and they can be very troublesome to manage, actually. So you tend to sort of do everything you can to avoid that. So that's probably the biggest thing, when I was training with Prof. Hannah in London, that we did. We used to liga clip everything as we went along to sort of avoid that if you could.
Okay. There's another question in the group. Any trials about surgical treatment? Well,
In general, so yeah, so there are, I mean, so yes, I mean, I think, look, so what I do think in terms of gastric cancer, so if you look at, surgical techniques, I guess is one of the things. So um in gastric trials, I mean, I guess that the latest is the Logica trial, laparoscopic versus open gastrectomy trial, which showed no real benefit to laparoscopic surgery, which was interesting, in all honesty, in the short-term outcomes. There will be trials coming in, robotic versus laparoscopic and robotic versus open gastrectomy. Richard van Hilgersberger has a Logica 2 trial, which has just been funded partially by EAS to look at this. And we have a trial which we've submitted called Organ, which is also looking at this as well, to a certain degree, which will come hopefully at some point.
And then could I just ask the Relogo trial, which sounds really interesting as well. Given the difficulty that Renaissance had, do you think it'll be tricky to recruit into it, or do you think it'll be?
I don't know. I really don't know. So what I would say is there's huge appetite for the trial. I
Yeah.
must say, like getting so we do a lot of trials, so like Lizzie and I both, and getting letters of support was not difficult for that trial. I must say, like most centres in the UK really wanted to take part in that trial. So there's definitely appetite to do it. The question is that if, I mean, but in a way, if you can't recruit to that trial, then it perhaps shows that your definition of oligometastatic disease is probably too tight, maybe. I mean, we need to think about it anyway, at least. So that's one thing. The other thing I would say is that we probably also need to think as a country as to where these patients should be managed. These patients have pretty advanced cancer. They need a high quality molecular oncological approach to their treatment, and they need to have pretty safe surgery with good thoracic colleagues, good HPV colleagues, good endocrine surgery colleagues as well, and also have good access to interventional radiology. And not every centre in the UK will be able to provide that. And I think we have to be honest in thinking about the implementation strategy more than the trial afterwards.
Yeah, so there's lots of kind of sub questions within that trial, even the definition being one of them as well, I suppose.
Yeah, and one of the things I think is interesting in that trial is that we'll look at ctDNA at multiple time points during the trial. So
Yeah.
Richard Owen, who's one of my colleagues with Elizia and myself, is really interested in that. Alex Gordon-Weeks is leading the trial as the liver CI for the trial, and he has a really outstanding translational program around spatial transcriptomics, which will be an important aspect of that trial in terms of characterization of both the primary and the metastasis, which I think will be very interesting to study as well.
Yeah, I think actually for Relogo, I know that there's, I mean, we would like to consider, M1 lymph nodes if we can get them to be routinely operable, right? But I think that there is a lot of kind of push. There's, you say that there's a lot of enthusiasm, but there's some pushback as well, because there are groups of individuals who hold the view that these patients have metastatic disease and incurable and shouldn't be operated on. And so what I look forward to is, hopefully exploring this and having a positive trial, because it is about changing attitudes as well. Because, when we think about, when we're thinking about operating on someone in the MDT who maybe has more advanced disease, biomarkers are important, right? So, if someone has biomarkers that suggest that they're going to be really sensitive to immune checkpoint inhibitors, that patient's going to do really well, right? Or if patient has HER2, that patient is going to do well. If they're going to be quadruple negative for HER2 Claudin and PD-L1, that patient's going to do less well. And so these are the factors that we need to consider in changing this kind of really one size fits all kind of doom and gloomy mentality about gastric cancer. And also for older patients, we should be treating more patients who are older. I'm not saying that you should operate on them, Charlotte, but
No, I hear that.
Great. I'll do one final call for questions. There doesn't seem to be any more coming in there, but I might just ask one last question just about my invested interest again in HER2. Dr. Smith, do you see HER2 low coming into the field at all with gastric cancer? And are you working on it yourself at the moment? And do you feel that it's going to become more of a spectrum rather than a yes/no answer when it comes to HER2?
Really good question. So HER2 low is useful in breast cancer. I think though we need to take it in context, because HER2 low in gastric cancer, there were interesting response rates to trastuzumab deruxtecan in Destiny Gastric 01. But the response, the heterogeneity aspect of gastric cancer, I think, is difficult sometimes to tell apart from HER2 low. I think that it's slightly different from, for example, breast cancer in that regard. So I think that there's potential But I think that there are so many other targets that I wouldn't just overly focus on HER2 low at the moment. But you're right that the accurate quantification is something that we should be thinking about, not just for HER2. So, in metastatic disease, HER2 positive patients, you know how many cells they need to be positive? You know this, 5 cells. It's ridiculous, right? So, but they could have, a HER2 positive patient could have anything from 10% of cells positive to 90%. And of course, they're going to derive a differential benefit from different targeted therapies, especially when we have multiple biomarkers coming to the fore. For example, we'll have Claudin, we'll have MET, EGFR, blah, 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 right? So what we'll need to do is, develop a system where we're actually calling the proportion of cells that are positive on a biopsy, and then we will at least be able to make informed decisions about how useful a targeted therapy will be. That's what I would like to see happening. And that should be easier with digital pathology.
Yeah. Yeah. Enter AI, I guess.
Yeah, for sure.
Brilliant. Okay, well, we're exactly on time, and there doesn't seem to be any other questions coming in there. So I think that's everything then. So it just leaves me to thank you both very much for a very interesting discussion on all the relevant big trials of late. And thank you for a lovely discussion. And thank you everyone for attending. So
Well, thanks for the invite. Thanks to all my surgeons who cure my patients. Except for MSI.
Can we record? That's recorded, right? Yes. Thank you, Claire. All right, brilliant. Okay. All right. See you later.
Okay.
Thank you,
Have a
everyone.
good evening. Thank you.
Bye.
Bye-bye.
Bye.
thank you.